So the peripheral organ, the laptop was fine, and we thought that the optic nerve is gone, that is the channel. We tried to start with the brain, which is the central console. It didn't work there also. So we come back to the other channel, which is the right eye now. So the left channel is gone. So I'll be talking in brief about the amblyopia, and this is going to be a brief overview. I think most of us, we know about it, and most of us have been kind of following the ATS studies, all of them. So let's talk about amblyopia. Amblyopia is a reduction in the visual acuity of one or both the eyes caused by abnormal binocular interaction in the critical period of visual development. And there's no anatomical structural abnormality in the eye or the refractive error. So clinically, we define it as a difference between the two lines of two eyes, or none of the eyes reaching 6/9 or 20/30. And it's the most common cause of monoocular vision loss in children, amounting to approximately 3 to 6% of children. Now, types could be anisometropic due to blur of the image, strabismic because of the abnormal binocular interaction, visual deprivation because of absence of formed vision, or a mixed, which could be a combination of all of the above, or rarely reverse occlusion when we were practicing full-time occlusion. It could cause an occlusion amblyopia. The success lies in the early detection and the proper institution of therapy, because it has to be done when there is a cortical plasticity and the patient has not attained visual maturation. But we all know that sometimes even the adults can be treated for amblyopia. So is it just a reduction in the visual acuity? It's not. It's a visual function which has poor binocularity, abnormal contour interaction, reduced contrast sensitivity, positional uncertainty, spatial distortion, poor accommodation, abnormal eye movements, and suppression. Also, there are studies which talk about that the sound eye can get trauma because of the other eye being amblyopic. And here what we try to improve is the BCVA, binocularity, striopsis. If not all, at least some of them can be achieved. The idea in the present day's competitive world is to improve the BCVA, improve the confidence and personality of child, and make him fit for the competitive world and its future medical examinations. So counseling is the most important. We have to give chair time to the patient, make them aware of the time which has been lost and the time left to improve in the amblyopia. It's a team building effort. The optometrist who is giving the glasses, the ophthalmologist, and the parents and the caregivers, and child is an equal important partner. Child may cheat and re-cheat, so you have to counsel and re-counsel the children. And the toughest resistance we face here is from the grandparents, followed by the parents and then the children. So you have to counsel the parents and the grandparents also. Now, how do we achieve? The treatment options are the optical, the patching, the pharmacological penalization, and the dioptics, which are new. So optical is by far the most important, the first line of treatment. Correcting the refractive errors is the first and foremost thing. Give time for adaptation to the prescription of glasses, and at times we find that some visual improvement does come, if not full, with just giving glasses to the child. Patching is the gold standard, where the brain is forced to see with the amblyopic eye. Traditionally, we were taught the full-time patching, but then came the PDIG and the ATS with a lot of studies. So we went from full-time to part-time, which works 6 hours a day for severe amblyopia, and 2 hours a day, which is equivalent to 6 hours a day for moderate to mild amblyopia. Then we talked about the pharmacologic penalization, which is also looked upon. So again, it goes off. So atropine penalization, again, it was talked of by the ATS. So prerequisite here is when you do the atropine penalization, even with the refractive correction, even with the penalization, the visual acuity of the worst eye should be better than the sound eye, only then it is going to work. So PDIC talked about, weekend only compared to daily penalization, which is equivalent to patching in mild amblyopia. Now, dioptic treatment is a binocular treatment without patch or penalization. So it's a newer technology which has gained most interest. But we know that I think ATS20 had talked about that the dig rush did not work as good as patching. So they are all new forms of technology, may use red beam anaglyphics or polarized glasses. The common ones which are being used are the dig rush, falling blocks, iBit, occlutab, binocs, and revital vision. So the clinic-based can have issues like the patient has to be called again and again to visits, repeated visits. They need monitoring by the optometrist. It's a difficult situation in Indian scenario because sometimes you have patients coming from very far off places. Also, there are limited games. After a couple of games, the child loses interest, which I have found in my kind of limited experience with the occlutab, because we did try. But then the child used to say that this is not, kind of my kind of games, and they refuse to play, or they refuse to pay attention to the repeated games we're talking about. Home-based have come up in terms of, binocs and dig rush. they are more beneficial as compared to the clinic-based because they have many games. It's a possibility of online monitoring, and maybe in terms of they may be a little more cost-effective in terms of not imposing a cost of transit from the home to the clinic every time. Now, there are some magic claims, especially like this, which was sent to us a few days back. This was an email I think we all received. So this was an adult who was having a hyperopia in one eye and was given contact lenses and revital vision for about 60 sittings, that is 2 months. So, and I think most of us would agree that if you give optical correction and give 2 months of time, the child would probably improve, or an adult would probably improve from 6/12 to 6/9, even without revital vision. So weaning is an important part. It should be planned. A gradual decrease over a period of weeks, and eventually stopping in the hours of therapy is the kind of weaning what we do. So when do we wean? We wean when the child reaches 6/9 or 6/6, or the maximum VCVA has been achieved for about 3 months. It is again gone. So the important here is to make the child and parents aware of the regression, because it does occur in up to 20 to 25% of patients. And whenever this occurs, there should be a longer and slower weaning rather than a rapid weaning. Now, some tips like candies and toffees do help in building the rapport with the child because they are the most important partner in their treatment. Visual deprivation and strabismic amblyopias, you have to make aware that sometimes a full-time patching may be required if the part-time patching is not working for the child, and the parents and the child should be ready for it. For an isomyopes and aphakics, contact lenses along with the therapy works better if the glasses are not working for these patients. After completion of therapy, the follow-up is very important because sometimes the child do regress, and it is very important to pick up regression early and reinstitute the therapy early. So treating an amblyopia is an art rather than a science, and you have to choose the best suited part of treatment depending upon the severity and the type of amblyopia and the compliance and the ease of use in a particular patient. Thank you for your kind attention.